Columbia University Faculty of Science Alumni Association, CUFSAA, proudly presents a distinguished speaker series to uplift the knowledge of aspiring students and budding scientists in the Faculty of Science at the University of Colombo and Sri Lanka as well. In this series of lectures, CUFSAA features accomplished scientists and key opinion leaders in different science streams to present the advancement in their field of expertise. This seminar series is a collaborative effort between CUFSAA and the Columbia University Faculty of Science. Welcome to the Distinguished Speaker Series of CUFSAA.
Indika, I think you are on mute.
Okay. Yes. Welcome again, everyone. So today our topic is real-world application of biostatistics and health research, and our speaker is Dr. Soutik Ghosal. Before we begin the talk, uh, let me give some a few information. So at the end of the talk, we will have about 15 minutes Q&A session. But please feel free to share your questions either in the Zoom chat or your live streaming comment section. We'll get to it at the end of the talk. And also at the end of the talk, feel free to unmute yourself and ask questions. But please wait until the end of the talk if you are unmuting and asking the questions. But feel free to type in any questions during the talk. And again, today our speaker is Dr. Soutik Ghosal. He is an assistant professor in Division of Biostatistics, Department of Public Health Sciences. He joined UEA faculty in 2022. Before that, he was a postdoctoral fellow and a research fellow. Dr. Ghosal obtained his PhD in biostatistics from University of Louisville in 2018. Dr. Ghosal's methodology research interests span various areas of biostatistics such as diagnostic accuracy modeling and biomarker analysis and spatial temporal modeling. He has developed methodologies in applications in neurology, pediatrics and women's health disorders, health and medical disparities, and observational studies. During his doctoral and postdoctoral training, Dr. Ghosal collaborated with medical doctors and practitioners of diverse backgrounds, including cancer, cardiovascular diseases, in vitro fertilization, and pediatric health. Dr. Ghosal has more than 35 publications in peer-reviewed journals. It's my pleasure to welcome Dr. Ghosal to our 13th talk of CUFSAA Distinguished Speaker Series. Dr. Ghosal, please go ahead and share your screen. Thank you.
Sure. Thank you so much, Indika. Let me, can I, okay. Can you see the screen?
Yes.
Okay. Thanks again, Indika, for such a detailed introduction, and thanks to CUFSAA for allowing me to share my research, my perspective about the journey that I have made so far. I really enjoy my job, and if you talk to Indika, you'll know I'm really passionate about how how things function at where I am, and I'm really excited about the role that we biostatisticians and statisticians have in the field of medicine, to be specific. So based on that, I'm going to share some real life examples that I have come across. Want to share with you how what our roles are to kind of improve the field of medicine, biomedical research in general. So to start with that, I'm going to briefly share my journey from where I started to my current role, and then share some different examples spanning my research interests like spatiotemporal modeling and different type of disease screening, including Alzheimer's and other maternal fetal outcome. And of course, I'll end with the lessons that I have learned so far and my key takeaways on the strong do's and don'ts that we as a biostatisticians should be doing. So I'm from India, so my bachelor's and master's degree are in statistics, which I got from the University of Calcutta, specifically now the Presidency University. Uh, and after that, I chose to move to Louisville for pursuing PhD. It's interesting because like almost at the end semester of my master's, this was not my plan. I don't know how things are like regarding teaching statistics in other countries, but in India at the time where like 10, 15 years back when I was a student, um, the statistics was mainly theorems, proofs, more towards mathematics, less on application, probably because like our teachers didn't have strong exposure to real life data because the you require database management, you need medical research happening, which was severely lacking at that point of time. So the natural course was for most of the stat graduates was to kind of pursue industry, like in banking sectors, accountings, less on biomedical field. But on my last semester, we had a teacher who actually moved from US to teach in my city, and he brought in all his experience, different data sets that he had worked on. The style of teaching applied statistics, or using statistics in domains like biostat, that completely changed my perspective about what I really want to do, and that motivated me to kind of uh, decide that I want to do PhD in a very, very short span of time. I moved to Louisville to pursue PhD, and that experience was really interesting and inspiring for me. That further motivated me to stay in academia, and I moved to NICHD. It's the Child Health and Human Development Institute within the National Institutes of Health. Um, and after completing my postdoc, I moved to UV as an assistant professor. And during this journey, particularly from PhD to my current year, I have been handling different statistical areas like spatiotemporal modeling, where you, if you're not aware of it, essentially your outcomes are spatially correlated, so that has different for types of correlation assumption. And if the outcomes are also temporally correlated, how we can model it simultaneously. And there are interesting applications of this area. Um, After my PhD, when I moved to my postdoc position, I had to pick up a different research interest, which was basically biomarkers and diagnostic accuracy modeling, which basically is how to quantify the performance of different biomarker, particularly in predicting diseases and tests, etc. And that has become my primary area for several years. And I've applied all these methodologies in accounting for health disparities, social understanding the impact of social determinants of health on different diseases and outcomes. Um, the diseases and outcomes include maternal and fetal health, neurological disorders like Alzheimer's. And while I was developing methodology as a PhD and as a faculty, there is another aspect of the research that's really strong, at least at UVA or any big medical schools, which is collaboration. Since we are in the School of Medicine, a significant part of our job is to aid the medical doctors to kind of help with their research. So we provide biostatistical support, and I found the collaboration to be really interesting and important, not only in academia but also as a PhD student, because I've seen most of the statistical methodology that in the current era we develop are motivated by real life problems, and the medical doctors bring the problem themselves. So the collaboration became a really important part of my journey, because that has helped me kind of understand real life questions. And my job, or the job of any biostatistician, is to use data, because nowadays in almost any domain, particularly in healthcare, we have abundance of data, like be it from electronic health records from hospitals, or surveys, or patient-reported information from questionnaires, to medical tests, imaging, so many of them. And all these data come with their unique challenges, particularly in medicine. We have a peculiar biases that only exist in this domain, might not be present in other domains, and mitigating that bias, or understanding how to perform analysis, keeping those biases in mind, um, is a real challenge, along with other challenges that medical tests I'm talking about. They're often imperfect. How to choose the right one, the best one for the right cohort. Uh, Diseases, many diseases are often detected too late. So how we can improve the disease detection, um, kind of detect it as early as possible. So those challenges are there, and that's like that's what make our job really interesting, because our job is to make the best out of the data, kind of interpret it in a way that it's usable by the clinicians. Of course, develop appropriate methodologies which could be used by clinicians, or used by applied scientists or other scientists to infer, predict, etc. So the ultimate goal is basically to transform the complex, messy health data into something that's clinically interpretable and has potential to inform and improve public health. So in my experience, often I've seen it could be me or some of my collaborators. They will come up with certain research questions. Like I share some examples, like, okay, Alzheimer's, can we improve the detection? Can we detect it earlier? Can we identify pregnancies which have higher risk of adverse outcomes? Can we improve a medical test? Can we improve the diagnostic capacity of a biomarker? Can we see if other factors impact the performance of a biomarker, etc.? And in all such cases, the theme is we have the health data. We get the data based on a question. So question comes first, then the collaborators collect data. Based on the question, we develop statistical methodologies to answer certain clinical insights, like it could be disease detection, risk assessment, so many things, so that the output that we get from the analysis has potential to kind of improve patient outcomes, inform public health standard. So that's the theme. And based on this theme, I'm going to share some examples. The first one is from the spatiotemporal aspect. And this is a project that I've worked as a PhD student. And interestingly, since I was saying that often the problems are brought us to a, like, um, like by our collaborators, they bring the problems to us. And once the problems is, of course, is a big problem across the globe, that access to healthcare is not equal. And that's true for United States as well. Uh, so the Department of Sociology faculty, they brought us the problem. They identified that many counties, at least from year 2007 to 2012, in United States face unimaginable shortage of primary care physicians, which they refer as health profession shortages. And this shortage vary across geography. Like this is the data for 2007, where I have plotted the number of medical doctors per 3,500 residents. So it's population adjusted numbers. And I've plotted it for different counties, and you can see they're like in the central part of like in the Midwest or central of North America, and of course, uh, uh, in some states in South, you can see so many yellow spots, and you will see darker spots, which of course are the counties with six or five or six or more number of doctors. So you can guess that uh, there are severe shortages. More than 10-15% of the counties have no doctors, no medical doctors at all. And these spatial pattern actually change over time. It's a huge burden on the public health. So understanding this pattern is really important for healthcare planning to improve the um, uh, like healthcare access for patients across US. So statistically, it was really complex. So you can, these are count data, right? So number of doctors, uh, but we cannot model it using known distributions like Poisson, negative binomial, etc., because there are like excessive number of zeros, more zeros that a regular count distribution can handle. But from that, there are counties nested with states. I will explain what that is. Of course, there are repeated measurements over time. What I mean by counties nested within states mean, of course, counties are part of states, but the characteristics of counties are very unique because if you go back, you will see there are often spots, deep spots, but like the in the surroundings you will often see light spots, which basically says that often there will be one county with higher number of doctors, so the neighborhood counties will not ever feel of having a doctor. So that's why there will, and people will have to move to the neighboring county to kind of see a doctor. And also, so that's why the counties are spatially correlated. There will be interesting spatial correlation with respect to that. But also there could be other factors impacting the number, like outcome for that county, which could be impacted by state level policies. So there are interesting, variance sharing situation for that outcome that were needed to be considered. The primary research question that we were the sociologists brought to us was like they want to know what factors influence the doctor's choice to decide a particular county to kind of practice, right? And they brought us different information like population size, demographic information, healthcare information of that county, racial and biological sex markup of that location, rurality, etc. And we had to develop a interesting statistical model which can account for all these complexities. We cannot go for traditional count model. We chose something like a hurdle model, which basically separates the zeros and the positive counts and model it simultaneously. We chose a Bayesian route to perform this hierarchical modeling because there are like spatial hierarchy, uh, nested spatial correlation, and of course we assume that the spatial structure that I've shown you in the map that could change over time. So the model should be flexible enough to account for that time varying aspect. I'm going to not show you the results, but to summarize what we learned, we basically had to model it. We found, as you see, there's a geographical clustering that exists, and the factors which were found to be as strongly associated with the outcome, the number of medical doctors, was population size, which is like no-brainer because if a county is populous, we expect their to be like we expect the county to have more doctors, but also other factors like healthcare resources, rurality, per capita income, like of that particular county, birth and death rate, all that impacts the choice of or the number of doctors. And the finding why these things matter, because these information will be crucial to kind of improve healthcare policy decision. If per capita income could be improved for a particular county which has less number of doctors, it's now up to the state or the county officials to bring in resources, identify underserved communities where they can feed in all these factors so that the healthcare could be improved. So this could be one of such examples where like the findings have potential to improve policy. I'm not saying this actually did, because no single work ever impacts the policy by itself, but these are all stepping stones that we can use to inform or improve public health policies. Before I go to my next examples, I just want to, like, in case you don't probably already will, I want to make you familiarize with certain basic definitions, which will be useful for next few examples. One of the things is definitely biomarker. Probably every one of you will know a biomarker is a measurable characteristic that provides information about a person or a living being's health, disease status. There are different types of biomarkers, diagnostic, prognostic, based on its role, whether it's going to diagnose a disease or assess disease progression. We're not getting into that, but overall, a biomarker will measure something, and it should have potential to identify certain diseases or underlying disease progression, etc. Some known ones are blood glucose for diabetes, cholesterol for heart disease. We all know that. The key question is, can a biomarker help distinguish between healthy and diseased individuals? Short answer, yes, because that's the primary role. We all have, most of us might have done blood tests. We know once we have a blood test, we get counts like RBC counts, hemoglobin count, etc. And based on that number, the doctors can tell us whether it's low or high. And based on those cutoffs, those values, we can separate they can separate the cohort into healthy and disease. So biomarkers have potential to separate healthy and diseased individuals. And for medical tests or any biomarker scores, how do we evaluate? Like, how do we know that a particular biomarker like glucose is good enough to predict diabetes? So for such cases, there are underlying statistical methodologies. So often, like in reality, no diseases or no biomarkers are perfect. So the way we evaluate is like, first we know the true levels who are healthy and diseased. We collect biomarker information without ever referring it as a biomarker for that disease. Let's say we collect blood information from a pool of patients with certain disease and a control who don't have the disease. So we know their true levels, right? And we collect information like, let's say, blood sample. And based on that, we have test positive and test negative outcomes. So true level and test outcomes based on these four subcategories, we can think of these four different unique situations where both disease and test agree, like both are saying they are positive or disease is there, and both are negative means disease is also not there and it's also tested as negative. So these are the cells where we want frequencies to be high. The off-diagonal ones are errors where disease and test don't align. So for a good biomarker, we will want these two cells to be as close to zero as possible. But in reality, it never is like that. But based on this matrix, which we refer to as confusion matrix, we can develop several measures. Two key measures are sensitivity and specificity, which sensitivity is basically saying out of the cohort who has disease, how many of them are correctly identified by the test. And specificity is the a healthy version of sensitivity, meaning out of the sample who are healthy, who don't have the disease, how many of them are correctly identified by the test as healthy. So these two are more used measures. There exist other measures as well. So we can use this metrics to evaluate a medical test. But the point is, like, which one should we use? Should we use sensitivity or specificity? Because often there are trade-offs. Like if we try to improve sensitivity, often we lack specificity. So there are measures we can summarize using the sensitivity and specificity measures. So one thing to remember that this confusion matrix is based on a particular cutoff. Like let's say one hemoglobin cutoff you choose. If you choose different cutoffs of hemoglobin, maybe for this you will get different forms of this confusion matrix, right? So if you choose a very low threshold, and let's say assume hemoglobin will not be the right answer. Let's say blood pressure. So if we choose, we know higher blood pressure means bad, low is also bad, but let's say low is good for this example. So if we choose a very low threshold and we say below this cutoff, everyone is healthy, above this cutoff, everyone is diseased. Then if we choose that cutoff as very low, we will definitely identify all the diseases. We will have 100% sensitivity, but we will identify many false positives. So the specificity will be bad. But if we choose higher threshold, we'll see the opposite. We'll have 100% specificity, but very low sensitivity. So how do we handle that? So RC curve is one way to kind of summarize the entire sensitivity specificity spectrum. So it basically summarizes the performance by choosing varying cutoff, and for each cutoff, they will have a sensitivity specificity pair, and they will plot it to get this curve. But then how do we quantify it? So we can quantify it using area under the curve, which is called AUC. So you can guess that uh, if the curve is very close to this diagonal line, the area will be 0.5. But as we move away towards top left, the ROC curve will result in higher area close to 1, which means better performance of the biomarker. And 0.5 means like a simple coin toss has the same performance of detecting a disease. So AUC is basically a summary of sensitivity and specificity, and we often use it to quantify the performance of a biomarker. And just remember that the range of it, 0.5 to 1, mainly kind of says how the biomarker is separating or discriminating the outcomes. So we'll use this AUC. I just wanted to kind of introduce that before we talk about some examples like Alzheimer's screening. So just to share some basic stat about Alzheimer's, it's a global burden, not only in US, but in US in next 30 or so years, it's expected the current prevalence number will nearly double. Globally, it's projected to reach around 19 million by next 10 years. And the prevalence is not uniform across population. In US, it's been seen that two-thirds of the Alzheimer cases are for women. And if we look at it racially, Black and Hispanic Americans face a significantly higher odds than white cohort when it comes to the risk of Alzheimer's. And it's a very slow disease that gradually develops over years. And it's often we detect it when the patient has age of 65 or higher, because then he will show certain cognitive symptoms. There will be loss of memory, there will be slurry languages, etc. So earlier detection before the cognitive decline even happens can really improve the clinical care research. So there exist different types of biomarkers, cognitive biomarkers and biological biomarkers. Biological biomarkers include fluid based on blood, cerebrospinal fluid, etc., or imaging. Now, there are still caveats, like main caveats are that I just mentioned about true levels, right? For Alzheimer's, the gold standard level doesn't exist for a living population. So it's only during autopsy when we get to know whether a patient truly has Alzheimer's or not. But for the living cohort, usually the cognitive decline is used, cognitive tests to kind of characterize their disease status. Um, but as I mentioned, when the cognitive symptoms uh, start showing, the onset of Alzheimer might have already occurred. But the biological change happens earlier. So the change in brain, the change in blood might happen in earlier. But um, among the cohort who has biological change, they not necessarily show cognitive decline in 10, 15, even 20 years. So it's hard to kind of guess when the patient really is starting to show certain biological changes. So because the concordance between biological and cognitive marker are very low. So that's the real research gap that exists in this framework. Uh, so like for cognitive biomarkers, there are different types of scores, different types of tests for different domains like memory, language, visual, spatial function, executive function, etc. I mentioned fluid biomarkers include blood and CSF proteins like amyloid beta, different types of taus, imaging biomarkers, MRI, PET, etc. MRI could be structural or functional MRI. Nowadays, functional ultrasound are also getting popular to like identify this kind of diseases. Now, the research has been done to like quantify the performance of these CSF blood biomarkers because these are easy to get. Simply blood, like CSF is still hard, but blood, you can simply like do a blood draw and you will have proteins and you can kind of do all type of measurements to identify how much of amyloid beta, tau, p-tau, quantify all these proteins in blood and CSF. So the question is like, which one performs better? So in one of our analysis, we used the EDNI database, which is one of the largest Alzheimer databases for US cohort. And the analysis was simple. Like simply we checked the diagnostic performance of these three biomarkers, and we can see that amyloid beta has substantially higher performance in discriminating cognitive normal to any type of impairment, followed by tau and p-tau. But so we know that like if we have to kind of get CSF biomarkers, which one to use? It's amyloid beta, right? But I was also interested to see whether the performance uniform, because often performance of biomarkers are not same across uh, entire population. So as I mentioned, like it's 2/3 of the cases are of Alzheimer cases are for women. So I really wanted to see whether biological sex impact the performance. So I just brought in a demographic information, biological sex, male versus male, and simply did the analysis for and estimated male and female specific AUC. And that's where we see quite interesting findings. So we see for amyloid beta, male has higher or stronger performance for um, amyloid beta for male, but tau and p-tau has higher AUC for female. And it's interesting. Previously, we saw that on an average, amyloid beta has higher, but if we focus on female, maybe tau protein works better than amyloid beta. So the key takeaway is like, of course, diagnostic performance of all these proteins may vary by sex. That it suggests that biomarker effectiveness is not uniform and could vary across biological sex and might inform that, okay, if now after it's validated appropriately, now the clinician, if there is a female patient coming to the clinic, maybe it's better to like get the assay from the tau protein than amyloid beta for that female. But if it's a male, they can use amyloid beta. So the results have potential to inform the practice for the Alzheimer's screening. But not all types of biomarkers perform equally well. I mentioned cognitive imaging and fluid. So if you refer to the imaging aspect, so imaging is slightly complex because it's a detailed procedure and different types of features from the brain are collected. For example, on the cortical level, on the surface level, cortical volume is collected or kind of computed. Cortical thickness, cortical surface area of different regions are collected. And when we go to subcortical, like inside of the brain, we can also collect a volume. And we have information of all these features in different databases. So what we did, I mentioned there are different regions, and it's known in literature that different regions give you signal based on whether it's a early onset of Alzheimer's versus late onset. So quantifying region-specific diagnostic accuracy is the natural next step, right? So these are the top row is basically cortical volume AUC estimate for different regions. You will see regions separated by boundaries, and the bottom row is subcortical volume. So I have AUC from cortical volume, subcortical thickness, cortical surface area, and also subcortical volume. Now, if I rank the AUC, the highest AUC that I got from the subcortical volume, particularly from left and right hippocampus and amygdala, followed by regions here. So you can clearly see that, of course, if you use surface area as a metric, it results in very low AUC. But if we use overall cortical volume, cortical thickness, then we get overall higher AUC estimates. But if we have to identify a particular region, then subcortical volume, like particularly subcortical regions like hippocampus and amygdala, come out to be the most predictive to identify any type of screening. It was sort of aligned with what existing research have found. It has implication, but now we have technology to do entire brain imaging, which is longer. It has sometimes impact of radiation effect, although it's very low. Um, but it's a long procedure. It could take hours, right? So patients often don't like this, like MRI to be done. And if you want something to do repeatedly, this is something we will see very high dropout rate. Will not get as many patients to comply to get MRI done. So this kind of say that if we identify only few regions, and if the technology can be transformed to get a small, to map the particular region in a substantially smaller time, probably that could be the next step. And for that, we can only use those handful region of interest of ROI just for that focused imaging. So I really wanted to see whether sex impact this as well, and we saw female having stronger AUC in most of the regions. So basically, it's saying diagnostic performance of different regions can also vary with like sex. Uh, so uh, what about cognition? We were talking about different biological markers, but the biggest problem, as I mentioned, that there are lack of alignment between cognitive and biological markers. So we are working on something. We want to see whether baseline plasma biomarker, I mentioned amyloid beta, tau, p-tau, etc., can they effectively predict change in cognition? So for that, I used a different database. It's NAC. It's cognition heavy, one of the largest databases in for the US cohort. So they have very rich cognitive biomarker information like composite memory, language, and executive function score. So using a simple mixed effect linear model, we are trying to see if we can predict the trajectory of these composite memory, language, and executive function scores separately using a biomarker, which is the ratio of amyloid beta and p-tau. And we can see we can see that the green line is for cognitive normal, orange and brown lines are for the trajectory for MCI, that means mildly cognitively impaired, and the brown line is dementia due to Alzheimer's. And we see that baseline biomarker can predict substantial faster decline for Alzheimer's, which is expected. So we definitely can identify, or we find a stronger association of decline with baseline information, but still it's not substantial. Why? Because if you see, it takes almost 10 years, like the predicted plot is showing that from baseline, it could take 10 years to show just 1.5 to 2 standard deviation difference, like decline from the primary from their primary memory score to show a 2 standard deviation decline. Often in cognitive literature, that's not substantial. So the problem is not completely mitigated. It's still there. So we have to, like, this is our ongoing work, but we have to find what are the best markers that we can use, which might show us stronger decline, than this, or probably as early as possible. So often it might on paper seems it's really interesting, but on the app, like when it comes to clinical interpretability, it's still not substantial enough. So I'll just share one more examples where I move away from Alzheimer's, the geriatric population, to the population of neonates and moms. I was at an ICHD, so I was working on certain projects where the objective is to predict high-risk pregnancies before birth, when the mom is pregnant, whether we can use ultrasound measurements, fetal growth measurements to predict the the outcome as early as possible, because fetal growth is a very important metric that we can use to monitor or predict different types of adverse outcomes. And for fetal growth, the route we take is basically ultrasounds. Pregnant women make ultrasound visits multiple times during their gestation, during their pregnancy, and during all these ultrasound visits, different types of measures are calculated. I will show that later. But the question is, whatever fetal measurements we use, can they predict which babies are at risk? It's a mix of yes and no. Some diseases quite well, some not as powerful enough. Uh, so I'll focus on a particular metric, a particular ultrasound biomarker called estimated fetal weight. So what it is, as the name says, it's an estimation of the fetal weight, because we cannot weigh the fetus, right? It's not possible. So we have to estimate the weight of the fetus, and we can only do it from different ultrasound measurements. Uh, so at different gestation, we get an estimate of fetal size, and doctors can inform us whether the fetus is growing in appropriate rate or not. And EFW, to obtain EFW, we have multiple ultrasound measurements like head circumference, abdominal circumference, femur length, biperial diameter. If any of you have seen how the ultrasounds are done, it's basically while the image is there, they kind of just draw random, not random, appropriate lines from based on, they can see the fetus and they can identify which one is the head, and they just put the points on different places, and there are technology that will quantify the length of head circumference, femur length, etc. And EFW is basically a composite of these metrics. So can EFW accurately identify babies? For our examples, yes. So the outcomes I'm interested are small and large for gestational age, which are basically when birth weights are below 10 percentile or above 90th percentile. Essentially, whether baby is too small or too big, based on percentiles. So they are not as crude as possible, like based on birth weight. So if you change population for different countries, these percentiles will vary, and hence there is no unique birth weight which corresponds to SGA and LGA. It will vary with respect to different population, but their uh, sharp version is LBW, low birth weight, and macrosomia. They have a fixed cutoff of 2,500 grams. Below that will be low birth weight. Above 4,000 or 4.5 kilos would be macrosomia. And these are important because all of these outcomes are associated with delivery complications, increased neonatal morbidities, etc. So the objective is to predict these as early as possible. So and there are literature which already did that. I was again interested in one particular question that always motivates me, whether the performance of a biomarker is uniform across cohort. So I wanted to see whether BMI impacts the performance. Again, very simple analysis. We bring in BMI as a covariate. We want to see whether BMI specific diagnostic accuracy of EFW changes or not. It was based on NICHD's own performed study. So basically, we applied ROC regression and kept BMI as a covariate and estimated AUC for EFW specific to different BMI groups like normal or overweight or obese. And I replicated this analysis for outcome SGA and outcome LGA. And you can see that for SGA, this for overweight obese cohort has higher diagnostic performance, like EFW has high diagnostic performance for the overweight obese cohort when it comes to predict or screen SGA. For LGA, the difference is not significant. So, what are the implications? So it says that, so these are the findings. So it's saying what is, or quantifying what are the AUCs. But why the biology is still hard to interpret, we don't know. And we replicated this for different sub cohorts. The signal is always there. For SGA, it's always stronger signal from the overweight group, but LGA, it's always mixed. So we still don't know the Y component of this finding, but it kind of says that we should be considering BMI specific thresholds. We should not use same exact thresholds for EFW to quantify healthy versus disease. Rather, it should be based on BMI. Not only BMI, it should be changed with respect to race as well. So all the metrics that I have shown, like EFW, ACFL, BPDHC, the growth of all these are known to be varying with respect to racial groups. So I thought the diagnostic performance of all these should also vary with respect to race, right? So I tried to estimate the AUC for at different, and on the x-axis, I have a visit from 0 to 5. It's spanning the entire pregnancy, but you will basically, to summarize what I've seen, that you will see for any biomarkers as uh, pregnancy proceeds, the AUC increases, irrespective of what disease we predict, irrespective of what biomarker we use, which is biologically validated. Uh, we get very good performance from EFW and AC. EFW is known, but AC is really comparable as well. So that's interesting. But you will see that I've plotted the AUC lines at different visit specific to different races. So you'll see often, uh, let's say, take this as an example, EFW predicting SGA. So at very early pregnancy, the AUC was quite high for Asian and Pacific Islander. Often there will be noises, but you can see the change in AUC has different rate after visit 4 or from visit 4. The diagnostic accuracy significantly improves for white cohort, but for the rest, it's more or less similar. Asian and Pacific Islander actually has declined performance. And this kind of pattern are often shown. So if you look at SG and use any biomarkers, you will always see similar patterns. After certain visit, the performance of white cohort is actually increasing. So there exists racial variability, and the implication is that we should consider race-specific standards. Um, so I've mentioned that I work as a collaborative biostatistician as well in the School of Medicine. So I had the opportunity to work with different medical doctors uh, across different disciplines. And often I've shared certain example research questions. So often they bring question to us. Okay, this is what I want to do. I want to see association of social vulnerability with readmission rate after surgery. I want to see whether a particular treatment has uh, improved effect in a particular region where healthcare access is not there. I really want to identify predictors which impact a certain disease. So often this see association, causality, disease prediction, risk assessment are the key questions they want to um, kind of answer. And for that, uh, when I was in my bachelor's and master's, I was thinking, okay, it's the data analysis part where we come. It's not true. Like especially in this domain, if we don't help the medical doctors to design the studies, there will be biases I was talking about. There could be sampling biases if not taken care of. Whatever finding we get will not be clinically interpretable. They will be biased as well. So our role doesn't like stay only developing statistical methods and analyzing the data. Rather, it starts from very start when the medical collaborators bring in a important interesting research question, we help them design the studies. We help them collect the data or kind of inform what kind of data should be collected, how the data should be managed, followed by analysis. And then we also have to help to translate, to interpret the results so that it naturally feeds into the healthcare decisions. So we have this like complete engagement in the entire process. And the I'll just end with my key takeaways. Like as a biostatistician, it's of course stat applying in health research. There's no question, and our methods can really improve the risk detection of whatever clinical insights where the collaborators are like interested in. And we of course work across medical specialties, but our role uh, are actually kind of should be, and we should be involved in the entire process of the study. And the collaboration in my experience has really been essential, because often we have identified certain biases, certain caveats in the data, which resulted into a particular statistical methodology which might not have existed if that particular problem in healthcare was not present. So collaboration is really important, and it helps us improve our methodology at the like development of the methodology at the end. So I want to end with that. I'm sorry I might have gone beyond 45 minutes, but I'm happy to take any questions. And thank you so much for being so patient to kind of hear what I have to say and share my research.
Thank you very much, Dr. Ghosal. Any questions? Feel free to unmute yourself and ask any questions, or feel free to type anything in the Zoom chat. Okay. There's one question in the chat. What would be your typical day as a biostatistician, assistant professor at UEA? Is it a lot of teaching or a lot of research or a balance?
Um, The role actually varies over the year. So I don't have a very strong teaching commitment. Usually I teach one semester a year. For the rest of the time, my typical day would be balancing collaborations and developing research questions for my own grants. When it's the time for teaching, I will try to kind of minimize my own statistical method development work. Uh, I cannot get rid of collaboration, because that basically brings money to the department for my salary. So when I'm teaching, it will be a good balance of teaching and collaboration, very limited statistical methodology development. But when I'm not teaching, it will be a good balance of collaboration and method development.
Thank you. There's one more question. Are these datasets accessible for further research?
Very good question. Most of the data that I have showed, at least the Alzheimer's data, are freely available following appropriate data user agreement. So if you want to use NAC data, ADNI data, you have to go to their website, kind of submit a proposal, and then the data will be made available to you based on what you need.
Let me ask one more question in general. So when you working with the collaborators with the different background, how do you handle? Sometimes, like we say that we don't speak same language, right? So how do you handle
Uh,
that?
this is something that I'm trying to improve, because I was horrible when I started collaborations. Because as you mentioned, the lingos are very different. I can share one very specific example. Is confounders is used very differently by statisticians and collaborators. So when I say confounder versus they say confounder, it completely means, like, when they say confounder, they mean simple covariates. But when I hear confounder, I will, okay, they want some sort of balancing or something else. So at first it was very bad. I'm still trying to improve that. So what things I try to kind of keep in mind is like when I'm meeting with my collaborators, I have a very specific set of questions, uh, which I really need answer. Like, what's my role? What's the future of this collaboration? Is it resulting in a abstract, paper, grant, whatever? After that, I try to learn about their involvement. Like they want to meet, like there are collaborators who are very hands-on. They will meet more, they will try to explain everything, they'll try to answer all of your questions. Some are not. So I try, based on our first meeting, I try to understand what type of collaborator is this person is. But I always have a set of questions, and I to get as much as information as I can in the first meeting. And then how I use my lingo, like how I want to kind of make it as like if I want to use layman's term versus I can resort to my stat lingo, depends on my first meeting. Like often my collaborators are very educated statistically. They understand most of the sophisticated analysis. So for them, it's easy for me to kind of be myself and use the right language. But if I can guess that, okay, this person might not have as much knowledge, so I try to understand more and use as much as layman's term as possible. I try to interpret everything. I try to reason everything. Like if I say, okay, I want to do mixed effect modeling, I try to say why I'm doing mixed effect modeling in layman's term as possible.
Thank you very much. Are there any other questions? We'll have like a minute or two. If yeah, if not,
I just see one last question
oh yeah,
about AI. uh, uh, yes, AI is still there. It's trying to creep in. I Nowadays there are interpretable AI as being used more in this domain because AI is still perceived as sort of a black box model by our medical researchers. So what most of them understand is like they feed in all everything and one prediction comes out, but often the prediction might not be interpreted like clinically. So AI is getting strong, but with caution. So as like I use like different machine learning or AI models as well, not to the full extent, but I try to kind of develop or kind of use AI and always have a purely statistical and biostatistical counterpart and try to interpret the distinction in findings as much as I can so that the strong interpretability is there. But they are there are more AI models specifically developed for biomedical researchers because of the biases I was telling. Like the clinical interpretability is important, the biases are important, and different AI models are being developed, keeping all of those things in mind.
thank you. Are there any other questions? If not, I would like to thanks again Dr. Soutik Ghosal for an excellent talk with a lot of practical examples. We really appreciate it.
Thank you so much for
And
giving me the opportunity.
and also we would like to thanks University of Colombo Department of Statistics Chair Dr. Dilshani Tesera, and I would like to invite Ms. Tisha De Silva to give a thank you note.
Thank you, sir. Good evening, everyone. As we come towards the end of this insightful session, it is my absolute privilege to propose the vote of thanks on behalf of the Stat Circle and the Department of Statistics at the University of Colombo, Sri Lanka. First and foremost, I would like to express our sincere gratitude to our distinguished guest speaker, Dr. Soutik Ghosal, Assistant Professor in the Division of Biostatistics at the Department of Public Health Sciences at the University of Virginia in the United States. Dr. Ghosal, thank you so much for taking the time to share your knowledge, experiences, and research journey with us here today. Your presentation on the real-world applications of biostatistics in health research provided a fascinating glimpse into how statistical methods are applied to address critical healthcare challenges. The examples you shared from your work clearly demonstrated the real-world impact of statistics in improving healthcare outcomes and supporting evidence-based decision-making. Beyond the technical insights, your reflections on your academic and professional journey were truly inspiring for our undergraduate students. We are deeply grateful for your willingness to engage so openly with our students and for delivering such an informative, thought-provoking, and motivational session. Our sincere thanks also goes to Mr. Indika Malavarachi, Senior Biostatistician at the Division of Biostatistics, the Department of Public Health Sciences, University of Virginia, and an Executive Committee member of CUFSAA North America, for his invaluable support and coordination in making this collaboration possible. We would also like to extend our heartfelt appreciation to CUFSAA for this wonderful opportunity. Thank you so much for providing this rare and valuable platform to interact with esteemed international lecturers. Opportunities like these are not only academically enriching, but also truly inspiring, broadening our perspectives and motivating us to aim higher in our academic and professional journeys. We are genuinely grateful for your generosity, collaboration, and commitment to supporting student development across borders. We are especially grateful to Dr. Samira Viswapula and Dr. Gayan Dharmarathan, senior lecturers, for this collaboration with CUFSAA. I would also like to thank and acknowledge the academic staff, alumni, and all participants who joined us this evening. Your presence, active engagement, and thoughtful participation greatly contributed to the success and vibrancy of this session. On behalf of the Stat Circle at the University of Colombo, I once again extend our deepest gratitude to Dr. Soutik Ghosal, Mr. Indika Malavarachi, Dr. Samira Viswapula, and Dr. Gayan Dharmarathan, CUFSAA, and all the participants for making today's session a truly memorable and meaningful experience. Thank you so much, and we look forward to meeting you all again at future events. Have a wonderful evening.
Thank you very much, Tishaka, for your nice words of thanks.
Thank you. Thank you so much.
Okay. Last thing is again to just to remind you this speaker series organized by CUFSAA, the Distinguished Student Series, and this is association with the Faculty of Science, University of Colombo. If you would like to contact speaker series subcommittee, you can use speaker dash series at cufsaa.org, our email address. And we are particularly interested in hearing you, from you with the topics and speaker suggestions. Thank you so much again, everybody, for the participation. And again, thanks, Dr. Soutik, for the nice talk. Have a good evening.
Thank you.